Hello, everyone. I'll give everybody another minute or so to jump on. I know we've still got quite a few people coming into the waiting room. I'm glad to see everybody come back. I'm going to mute some people. There we go. So welcome back to our sepsis awareness encore presentation. We have Tom and Natasha from Vivint Health, Ray from Mount Pacific, and Miss Pat Posa as a guest speaker today to go over some information. Mary, next slide, and we'll get going on Tom. Oh yes, sorry. Disclaimer as well, since we do have some people outside of Mount Pacific, there is some information that this presentation may contain some information and/or content supplied by third parties. The information provided does not constitute endorsement or recommendation by Mount Pacific. We are just sharing information that you all need or could use. Okay. Next slide, Mary. There you go.
All right, are we ready? So again, welcome everybody. I'm Tom Ahrens. I've had a background in critical care most of my career, focused on sepsis, also for about 30 years or more. A couple of real quick introductions. Natasha Diggins is going to show a little about a program we have on sepsis prevention and management. I know Ray's going to do a talk on data, which is always good. Then a very good colleague of mine, Pat Posa, is going to go over mechanisms she's used in the past very successfully, highly published, famous, even though she won't say that, in terms of implementing sepsis protocols. But what I always do on these, I like to start just with a few minutes and go over some background on sepsis. So some of you are probably already very familiar, some may not be. So let me just go over a little bit. So next slide, Mary. And so what we're going to do is, there's always figures that we can show, and I don't really like to go into these in great detail. Just a few key points, though. Sepsis is by far the leading cost in hospitals. It's also the leading cause of death. If you look at it in the context of infections, usually by themselves don't cause death. We always like to say if someone has pneumonia or even COVID, think how many people are reported to have died of those, when really what's happened is they've died of the body's response to that infection, which is what sepsis is. And so you can make a case that nobody dies of COVID by themselves. What they do is they die of sepsis. So let me go through just a little bit how that works. Next slide. So what I want to do is kind of show you a pathway here. What we are really all about is prevention. And when I talk about prevention, I'm talking about avoiding infections of any kind. Something that might seem very minor, like a cut on your finger, or cold or flu. Those, in some cases, progress much more rapidly into a more serious situation, and that's really what sepsis is. I'll show you how that works in a minute. But this little illustration here really shows prevention is the key. Most people come into the hospital with sepsis. They don't acquire it in the hospital or the nursing facility. They actually already have it, but it doesn't mean they can't get it in the facilities, but it usually comes into the emergency room with sepsis. But if it occurs, if we're not quick, if we don't do rapid prevention and early intervention, it gets worse, and it can get worse very quickly. And oftentimes it causes people to die. So we have an opportunity, and this is what Natasha and Pat will be following mine up with, is how can we kind of help avoid this? So next slide. So what I'd like to do is go over a little bit of some pathophysiology, and I want you to keep in mind, I'm going to give you an overview. This is actually an entire year course that we're going to do in the next 8 minutes. So this obviously some of the detail involved. We're not going to go into some of the real deep pathophysiology, but let me just show you a little bit. Go to the next slide. So when you look at the pathophysiology, we've talked about this for many years. Pat and I have done lectures on this for the last 20 years, and we've actually seen some similar content that we probably share. For example, this is a quote from William Osler. It's over 120 years ago. And he was very perceptive. And he talked about when people get infections, they don't die of the infection, they die of the body's response, which is really what I was saying in the beginning. If you get COVID, you're probably not going to die of COVID, but you're going to die of what the body's response to that infection is. And let me show you why that works. Go ahead, next slide. So, what happens when, if you look at any one of us right now, our body is so well prepared to defend us against infections that we're in many ways more in danger of our own body than we are of the invader. So if you get a cold and you get a stuffy nose and sore throat, that's not the virus. That's your body's immune system. Um, if you would say, for example, why would the immune system do this? Well, we don't know that. And that's really the biggest puzzle with sepsis is we don't know why it reacts in such a way that it harms us. But I'll show you on a very simple slide in just a minute. Go to the next slide, Mary. So I want to show you, this is an illustration that many of us have used for a while. This is you can see a big neutrophil and you can see a little bitty bacteria. You go ahead and click play. And what you're going to watch is this neutrophil is going to push aside red blood cells and it's searching for that bacteria. This is happening in us all the time right now. We never know it, but it's occurring. And so what happens is you'll notice this neutrophil never is resting. It's going to keep pushing and pushing until it can get to this invader. Then it's going to engulf it. It's going to pull it inside of itself, and then it's going to expose it to a vacuole that has a pH of about 6, and that will kill almost anything. So the idea being is that the neutrophil is one of our main lines of defense, but I'd like to show you this just to show you what happens in a normal immune response. Now, go to the next slide. And this is just another illustration. And again, sometimes we got to get out of this one before we can advance to the next one. But the next one is going to show something very similar. What it'll do is show that we have another organism like a monocyte. And a monocyte, I don't know if we can stop this one, Mary, go to the next one. But there we go. And that, click play on this one. And so what you're going to see on this one is, so these are like macrophages that are going to shoot out pseudopods to grab something that's foreign. And then what it's going to do is going to pull it into itself. And when it does that, it's going to see if it's dangerous. If it is, it will kill it. It will ice it. Now, in our body, there's no music playing like this here. But the whole point being is that when you look at what the monocyte will do, it's going to release a series of cytokines. These cytokines are like, they're going to cause a cascade of events that's going to protect us from an invader. And that's from Nucleus Medical Art. It's a very good site. Let's go to the next slide. So let's take a look at what would happen as we walk through this. It's really pretty simple. I think, see if we can get past that one. But what occurs, and let me just ask you a question. If you have anything pathologic on your finger, is your finger in any danger to you? And would you lick your finger? Of course we would. We do it all the time. And this gets like something like the 5-second rule. If we drop something on the floor, can we eat it? So let me ask you, what do you think? Can we do that? The answer is sure we can. Now you're taking a chance. You can ask yourself, do you feel lucky? But there's a good chance that you can eat stuff off the floor. Now, I'm not telling you should do that. I'm just saying if you're really hungry, you probably could. But the reason why you can is because our defense mechanisms are so good. And we're able to stop pretty much any type of infection from starting. Go to the next slide. And so what I want to do is show you what happens in terms of like, this happened to me personally, so I'll just share this with you. So this is my grandson, Sebastian. We're out of the park. He's riding a bike. He's a little bit ahead of me, and he stops and he yells back, says, "Papa, I found a binky." And I said, well, don't put it in your mouth. And when I get there, he's already got it in his mouth. And he said, don't worry, though, I cleaned it. There was a mud puddle nearby that he wiped it off in. And so when you look at that, you go, did that hurt him? The answer is no. He's fine. Now, again, I don't encourage you to do that, but the point is that you probably can. You're safe. Go to the next slide. Now, this next slide will be my granddaughter. Now, she fell, and now this is more serious because now what happened is she got a cut, and she broke her first line of defense. And so in this case here, now this is dangerous because our skin is so good at protecting us. We might have pathogens on our skin all the time, but as long as it doesn't get into our body, we're pretty safe. But this is a problem here. And so now what we're looking at is if we get an infection, it's most likely to come from something like this. Now, again, 99% of the time, it does not happen. But boy, every once in a while it will. So we have to treat every cut, any type of break in our skin or mucous membrane is a potential threat. So let's go to the next slide and I'll walk you through just something real briefly here. I want to keep this short. So Mary, click on the advance and it'll walk us through this little illustration. So this one, let's just say this is a dangerous pathogen, say it's Staph aureus. And so it's in our bloodstream. Go ahead and click the next advance. And so it's going to be identified as we showed you by a circulating monocyte. The monocyte is going to sense this to be indifferent. So it usually does this by what's on the cell surface. And when it does that, it's going to release a series of cytokines, interleukin 1, interleukin 6, tumor necrosis factor alpha, tissue factor. And we don't have to go through all these, but they do something very basic. If you look at what a monocyte will do is releasing these cytokines. Well, if we have an invader, think about what do you want to do? Well, we want to keep it localized. So what'll happen is we're going to start the coagulation cascade. So go ahead and click the next advance. And so what you're going to see is the coagulation cascade takes place. So factor 8A to 5A, 5A to thrombin, thrombin to fibrin. We get a fibrin clot. And this is great because now we're able to contain the invader. But this gets complicated because our body's natural fibrinolytic mechanism doesn't like clots. It will lyse this clot unless we stop it. So the cytokines do two other things. Click the advance, Mary. And then what you're going to see is things like thrombin activatable fibrinolysis inhibitor, or TAFI, be released. Plasminogen activator inhibitor, or PI, will be released. And these are going to suppress the body's ability to lyse this clot. That's good though, because even though it's formed a clot, it's going to trap the invader and now we can kill it. And so the monocyte that I showed you earlier, actually the neutrophil that I showed earlier, is basically encouraged to come into this area, and not just a little volume. We send millions of neutrophils into the area. And so what will happen is the neutrophils will penetrate through the capillary wall, which has been basically the endothelial wall becomes more permeable so the neutrophils can get in, and now they'll attack the invaders. Now, whenever you see this occur, you're always going to get some edema because the increased permeability of the capillary wall allows the neutrophils to come in, but also allows fluid to leak out. And so what happens now, the neutrophil comes in, but it doesn't stop there. We actually, at this point, will take a little bit of the invader. The neutrophil will leave it on the cell surface. It'll be identified by a T4 lymphocyte, and that lymphocyte will go back basically and cause antibodies to be formed. And so we're now going to get an antibody specifically for this invader. So when we see it again, we're ready for it. So this very simple explanation of the immune system, it's much more complex, but it shows how well we're prepared to defend against invaders. And so very rarely will an invader hurt us. Go to the next slide. But in sepsis, something happens and things go wrong. So instead of containing the invader, we start to see the basically immune system response spread to other organs. So for example, you might have somebody who comes in with pneumonia, but then their blood pressure drops. You go, well, that doesn't make sense. Or they have a change in level of consciousness. Those are unrelated to the infection, but it's the body's response. And what I want to show you, this slide just illustrates, we have tried all types of things to try and treat sepsis, and we can't find a good solution. So really, there is no solution for treating sepsis at this point. It's all about prevention and doing some basic early interventions. Go to the next slide. So what I want to do is we can follow the Surviving Sepsis campaign. We're not going to go into this in any detail. Pat's going to talk a little bit about it. But our treatments really are very simple. Try and make sure the person, if they have an infection, if we identified where it is, can we remove it? Can we start antibiotics? That's the key. Those are right there. Now, if we have the person's in danger, they have a high lactate, their blood pressure's low, we can't start to give fluids. And Pat will mention that as well. But we don't have many options here. Go to the next slide. So what I want to do is just keep in mind that every clinician, whether it's a nurse or a CNA, whatever, is taking care of a patient. You have to recognize when an infection is no longer localized. So if you have a infection and the person also may have an increased heart rate, a respiratory rate, they may have a fever, change in behavior, those are all warning signs to us called the systemic inflammatory response syndrome that we need to pay attention to because it's telling us the patient's getting worse. Go to the next slide. And so what I want to do is have Natasha show you a little bit about our program that is designed to help learn how to recognize or prevent and then recognize sepsis. And then after Ray's talk, Pat's going to show you her program. So Natasha, let me turn that over to you.
Okay, thank you so much. And thank you all for joining us today. My name is Natasha Dickinson. I'm the Director of Clinical Affairs with Vivint Health. Vivint Health is an education company that has partnered with Mountain Pacific to bring you all free interactive education on a variety of topics. The topic we'll be talking about today, of course, is sepsis. And as Tom mentioned, sepsis, there's no cure. However, it's all about prevention, prevention, prevention. So that's what our program's all about, is teaching our staff members how to recognize sepsis and how to prevent sepsis. Next slide, please. Okay, so if it's okay with you all, I will share my screen just to kind of give you a brief demonstration of what our interactive education looks like.
And excuse me, while she's pulling that up, I also put the link in the chat for our nursing home folks to join in as well. If we have anyone in a community standpoint, let me know and I can put that link in there also.
Okay, it's trying to share. Let's see here. All right. Just let me know you can see it, Jamie.
We can't. Oh, yep, no, you're good to go.
Okay, we're good to go. Okay, perfect. Okay, so as I mentioned before, Vivint Health, we are nurse-led, nurse-founded education company. You know, in our careers, we've been through countless amounts of education programs that are pretty boring. A lot of times you just kind of watch a video or you look at a PowerPoint to get information. So with our education programs, we want to provide education that is more effective and more engaging. And with this type of education, not only do your staff members have more enjoyment with learning, but it's also more effective and it leads to behavior change. So with our sepsis program, we have different programs that are designed not only for your medical staff, like your CNAs or your nurses, but we also have programs designed for your non-medical professionals, like your housekeepers or the dietary aides. We are strong believers that it takes a village to keep the facility happy and healthy. So we want to provide education for everyone. So today I'll show you briefly the CNA program, which kind of provides education about sepsis prevention to CNAs in a more specific way to them, how they can help with prevention. Okay. Now, as you complete our program, you will see that there are minimum words in our program. We are more about the doing aspect opposed to the reading aspect. So our learners, we want them to take them through interactive scenarios where they have to figure out what to do using their critical thinking. Okay, so with this program specifically for the CNAs are going to encounter different residents. Now, when they encounter the residents, they're going to have to take their vital signs. So first, we'll do that heart rate or pulse. So we're going to move our mouse here to check the pulse. Now, any movement that you see here, it's not going to be a video. This is actually me moving my mouse to have that movement happen. This is all about the interactivity that I mentioned before. This is very unique to any other education program because we're just not telling somebody what to do. They have to do it. Okay. Now, if we notice here, the heart rate was 102, which is elevated. We all know that. Now, look over here on the side where it has zones. Right now, it says green zone. As we get abnormal vital signs, you're going to notice that zone level changes. All right. So once we click continue, now we're in the yellow zone because we had one abnormal vital sign. Okay, we're going to keep on going and check that temperature. Once again, we're not telling somebody to check it. They have to actually check that temperature. So they're going to push the button and let's see what the temperature is. 101.6. We have another abnormal vital sign, it looks like. So now we have two abnormal vital signs, which is meaning to take immediate attention. As you can see, our zone level changed. Now we did this concept just because we want to make this easy for everybody to be able to recognize when there's a problem with sepsis. Early recognition is key to keeping your residents safe. Next, we're going to check their respiration rate. All right, and it's going to count for us. All right, it looks like it's elevated already. And at 28, we have another abnormal vital sign. So once again, we're in that red zone where we need to take action. Finally, as Tom mentioned with the SIRS criteria, there are those 4 criteria, the last one being the abnormal behavior. Okay, so once we get all of our data, the CNA will have to choose, what do you do next? So we know based on this zone right here, we need to alert the nurse now. Now, this may be a little simplified for some people, they may feel, but the whole point of this is to make recognition of sepsis easy. We don't want to complicate it. You know, the more people are aware of what to look for, the more we can get help and treatment right away. Now, other modules that we call them, and the CNA program specifically for sepsis, is going to have various topics like communicating about how to care for somebody who had sepsis. And the whole point of it is to just give a general overview of sepsis in an interactive way. Okay. These programs are all available to you just with a scan of a QR code or a touch of a website link. As soon as you scan that code or you click that website link, you have access to all of these programs. The additional program that you have access to is the vaccination program. And that is just another key way to educate about sepsis prevention. Okay, I'm going to just show you one more scenario here.
Communicating with the resident's nurse regarding any concerns for sepsis is extremely important. Preparation is key for effective communication. When talking to the nurse, be sure to provide the resident's vital signs, any behavior changes, and the concern for sepsis. Remember, residents with a diagnosis of urinary tract infections, lung infections like pneumonia or COVID, or wounds have a high risk for developing sepsis. If, after multiple attempts to alert the nurse to assess the patient is unsuccessful, contact another nurse, charge nurse, or medical provider. Remember, time is of the essence. If there is a concern for sepsis, the resident needs to be assessed immediately.
Okay, so that's just a quick overview of a video we have. We don't have very many videos, like I said, because we're all about the interactivity. I just wanted to show you one more thing with the interactivity. So throughout the modules, you'll also see a different concept with our teaching called discovery learning. This is a method that we use in which it's based on the concept that you can teach somebody something that they have no idea about just simply through discovery. So with this right here, the learner is going to have to decide how to communicate effectively. Now, if they would choose the wrong picture and the wrong column, it's not going to stick. So for instance, do you yell your concerns? No. So it's not going to stick. They have to discover that correct answer. And this is just a concept that you would see throughout the program to illustrate the importance of sepsis prevention and how to educate about it. All right, and if you all would have any questions at all, you can feel free to reach out to Jamie or even reach out to me at any time. I am happy to help, and we just want everybody to be educated about sepsis. Like I said, it doesn't matter what your role is in the facility. Everybody has a major part in prevention. Thank you.
And then I would like to introduce our own Ray Tupling, who will be going over some data for us. So Ray, it's all yours.
All right, thank you for having me, everyone. My name is Ray, I'm a member of the analytics team here at Mountain Pacific. I'm going to be talking today about some regional prevalence rates of sepsis and also some of the financial impacts that we see among the fee-for-service Medicare beneficiary population. I'll do my best to not be the population health boogeyman, but unfortunately, it's going to be some relatively bad information. That being said, let's get to the next slide. So just a quick preamble here. We're going to be looking at Medicare claims, primarily Part A inpatient claims, and beneficiary information on the cloud, which is basically just beneficiary demographics. We've got a 5-year time period we're going to be looking at. We're going to break it up into calendar years for ease of interpretation. And as I said, we're looking at Medicare fee-for-service bennies in Alaska, Hawaii and the Pacific Islands, Montana, and Wyoming. I should note here that when I say Hawaii, I do imply that I'm including the Pacific Islands in any data points associated with Hawaii. And if time allows, we're going to look at some CMS national healthcare expenditure data. I believe you'll be receiving these slides after the fact. I included that URL, so I highly encourage everybody to go to that URL. There's a ton of fantastic information on per capita spending out there, and frankly, it could be a presentation on its own. But that being said, we'll go to the next slide here, and we'll get a feel for what's the population that we're looking at and what's the population that Mountain Pacific serves and all of our partners serve as well. So we've got some relatively small states. I mean, Alaska and Wyoming each have under 1 million people. Hawaii and Montana are just over 1 million. Hawaii's got about 1.4 million, Montana about 1.1 million beneficiaries. So region-wide, we're still under 4 million people in total, 588,000 of which are Medicare fee-for-service beneficiaries. So I should note that Hawaii does have a relatively large Medicare Advantage population. Unfortunately, we don't have data for them, but we'll have a good story for our fee-for-service bennies. So anyways, that 588,000, that's our potential group that we're going to be seeing claims for. So let's move on to the next slide, and we'll see the frequency of sepsis claims throughout the region. Now, this chart here, we've got our year on the x-axis, so 2019 through 2023. Our y-axis is just the number of claims, and each color represents a state. So Alaska, is going to be that salmon color, Hawaii's green, Montana's blue, and Wyoming's purple. So what we see here is that in any given year, we've got a considerable number of claims, and we see remarkable consistency year to year in the number of claims. Even in 2020, as COVID rolled through our world, we continued to see sepsis. And I think, as Tom mentioned earlier, there haven't been any major breakthroughs in treatment. So it's still a consistent problem. It still is something we should adamantly follow and really, as he said, try to prevent rather than treat. So moving on to the next slide here. Again, we've got year on the x-axis. On the y-axis now, we have Medicare payments. Sepsis is an extremely costly thing, not only to Medicare, but for private insurers, Medicaid, et cetera. In this context, of course, we're looking at Medicare. I should note that these values are the actual values paid out by Medicare for these claims, the very same claims we saw on the previous slide. So it stands to reason that, as taxpayers, the more we can avoid a sepsis infection, we're all better off. And of course, that person doesn't have to experience sepsis. We don't have to dedicate hospital resources to treating sepsis, et cetera. So in the next slide, we're going to get to a data point I personally love, and that is cost per infection. So here we're honing in on calendar year 2023. So in Alaska, calendar year 2023, there were 2,197 sepsis-related claims. Of those 2,197 claims, we see that there was a little over $65 million paid out by Medicare for those claims. That gets us to a cost per infection of $29,670. All we're doing is taking the total amount paid out by Medicare, dividing it by the number of claims. And you can pick your state that you're interested there, and you can see what the cost per infection is. But really, this is a good number to have in the back of your pocket, especially if you're an infection preventionist, if you're anybody advocating for infection prevention resources. If you can say that each infection is going to cost X amount, in this case, each infection is going to cost anywhere between $25,000 to $30,000. All of a sudden, infection prevention training looks pretty affordable. Unfortunately, in the fee-for-service context, we don't quite make that link. And we'll talk a little bit later about how CMS is trying to make that link between prevention and cost savings. So moving on to the next slide, we're going to hone in on our nursing home population. And we'll look at, next slide, please. We're going to look at sepsis claim frequency among our nursing home residents throughout the region. Again, we see some pretty remarkable consistency, and in fact, even an uptick in 2020 as all the additional safety precautions happen in our society due to COVID. We see an increase in sepsis. So unfortunately, it's not as easy as washing our hands and wearing a mask, as you all know. So with that frequency of claims, we see consistency. Same takeaway message, no major breakthroughs in sepsis treatment. So we can go to the next slide and we'll see what the financial impacts are just for our nursing home residents. And again, we see some very large numbers associated with Medicare payments here. So the financial incentive to prevent these is there, well, almost there. But next slide, and we're going to take another quick look at our cost per infection. So we'll walk through Montana's here for this example. So in calendar year 2023, there were 278 sepsis-related claims. About $6.1 million was paid out by Medicare for those 278 claims, resulting in Montana for a cost per infection of $22,116. We do see slightly lower numbers among our nursing home population. Generally speaking, the reason for that is that it's typically caught a little bit sooner, as opposed to somebody who's living at home and may not know what signs to look for a sepsis infection. So they tend to show up at a hospital with maybe a further developed case or a more serious case. But that being said, we're still in the ballpark. Each infection is going to cost well over $20,000. And the sky's the limit as far as that goes. So anyways, I'm trying to, my apologies for going so fast, but I really want to get into this national healthcare expenditure data. So next slide, please. We've all heard anecdotal evidence on cost of care is increasing. Well, CMS provides us with some actual quantitative data to support this. Now they released this, again, it's public information. I included the URL on all of these slides that use this data. So if you get a chance, please go there. But they bundle all healthcare goods into what they call personal healthcare. And that's what we're seeing here. So on our x-axis, we still have the year. On our y-axis, we've got per capita spending levels. So just dollar amounts per person. And what we're seeing across all of our states and the US in aggregate, all of these lines have a very consistent trajectory upwards. And really the frightening number is that the growth rates for the US as a whole in aggregate, these per capita healthcare spending costs are increasing at about 4.7% every year. Now, again, these are inflation adjusted numbers. But really, it's every year from 2015 to 2022, you can expect personal healthcare spending to grow by 4.7%. Now, granted, this data is a little bit old, but I think it's safe to assume that trajectory is still going up. So we'll dive into the reasoning of why that red line for Alaska is so far above our other states in just a moment. But next slide, please. And we'll dive into the category that CMS refers to as hospital care. This is their proxy or their phrasing for inpatient care, essentially. We get a little bit closer between our different states, but really the one I'll call your attention to is that blue line. That's the US in aggregate. So inpatient hospital care is increasing quite dramatically. This one comes out to about 4.5% growth every year. And so really, where does it end? Moving on to the next slide, we'll finally get some explanation of why Alaska has such higher spending per capita relative to the other states. And that's due to what the CMS refers to as physician and clinical services, again, the proxy for outpatient. Outpatient services in Alaska tend to be much more costly. I don't have a good reason why. You'd think we'd see a similar story in Hawaii if you wanted to, go the geography route. But that being said, Hawaii is only slightly above the rest of the nation there. So I'd be interested to hear anybody's thoughts who may have a good explanation of why outpatient services in Alaska are so much higher. And finally, I'll round out my presentation here by looking at dental services. And this, we get still yet another reason why Alaska's personal healthcare spending is so much higher than everyone else's. Again, it's because dental services have higher spending as well, followed by Wyoming in that purple line there. But surprisingly, Hawaii seems to be relatively efficient at providing dental services to its population. It's actually below the national average. But again, we're still seeing an annual growth rate above 4%, even for dental services. So the question is, what is CMS trying to do to address these rising costs? And we'll go to the next slide. So CMS is, I'm sure you've all heard of it by now, they're working on things associated with value-based care and total cost of care. And really what they're trying to do, like that bold text at the bottom there says, they're trying to align the financial incentives with prevention rather than treatment. And when it comes to something like sepsis, that's exactly what needs to happen. Preventing it in the first place obviously saves the patient the having to deal with having sepsis. It also saves hospital resources, saves physician and nurse time. Everyone's better off when we prevent it. The question is, how do we tie the financial side of it to incentivize the prevention? And so that's why you see value-based care, total cost of care. Now, total cost of care just came up on its first year of actually being implemented. I believe it was first implemented in September 5th, 2023. And then value-based care and ACOs in general have been around a little bit longer. But in some ways, the jury is still out. We're still getting feedback on how these programs are operating. And so it's an exciting thing to be a part of. Do they solve all of our problems? Absolutely not. And are they perfect implements? No. But I think they are a step in the right direction. So that being said, that concludes my presentation. My email's on the next slide if you have any questions. And I'll hand it back to, I believe Pat at Vivint Health is up next, or Jamie if you want to take it.
Mm-hmm. And then next slide, Mary, and we'll introduce Miss Pat Posa, and she will go over how we'll be implementing some of these routines into your daily tasks. So, Pat, it's for you.
Hi, everyone. Can you hear me, Jamie? Can you hear me?
Mm-hmm.
Well, I'm excited to be with you guys today, and I'm just going to, so if you can go, we're going to talk about early recognition and management of sepsis in the post-acute setting. So go ahead to the next slide. What we're going to talk about is a program that we implemented in the state of Michigan in partnership with our QIO MPRO, and something that might be very applicable in your area as well. So it's where we assisted skilled nursing facilities to improve sepsis recognition and management, embedding sepsis screening or early identification into their workflow. And we put together a toolkit that's available to everyone to be able to do this work. So go ahead to the next slide. So here is our toolkit, and you will have a link to get to that toolkit, and it's allows you to an overview of how to use the toolkit, all the training materials, all the different sepsis tools and resources. So go ahead to the next slide. So in this program, in partnership with skilled nursing facilities, the objectives were to assist them in developing and implementing an early recognition of sepsis process, to be able to standardize processes for treatment of patients with sepsis, and then also to improve some infection prevention. So standardizing some processes related to infection prevention. And in skilled nursing facilities, 3 of the major infections that can occur are pneumonia, catheter-associated UTI, but more importantly, UTI, because you guys don't use many urinary catheters, and then central line-associated bloodstream infections, with the overall goal of decreasing the rate of transfer to a higher level of facility, which is both disruptive for the patient and the family, so the resident and the family, and it's also becomes very costly. And then to decrease sepsis mortality rates. So go on to the next slide. So this program we did, it was pre-COVID. So we ran this program from 2016 to 2019. And it occurred over a 6-month period with 1-hour face-to-face meetings monthly. You could do it virtually if you needed to, but at that time we didn't need to. And we had an action plan that we had each of the facilities work through to implement an early recognition program for sepsis, as well as a management program, and then some focus on infection prevention. And so we met monthly, and then we also provided some resources with coaching calls. We provided all the training and educational materials, and then we had them measure, right? So we defined some process and outcomes measures so we could evaluate the success of the program. So go on to the next slide. So we set some, which was key, we set some facility expectations because it was important that the facility would be all in doing this program. And so each facility needed to have a sign off from the administrator, and that part of the expectations were that they would create a team in their facility, usually recommended to include the medical director, director of nursing, and the infection prevention nurse to do this work. And this team would then work through the action plans that I'll show you in a minute over this 6-month period. So they would implement a sepsis screening process, implement early management of sepsis. They would educate the staff on doing that screening and managing sepsis, and that education would be at the time of implementing the program, but it would also be put into their onboarding process so that this would continue and you would have sustainment. And then they were expected to assess their current infection prevention practices related to pneumonia, UTI and CAUTI, and CLABSI to identify an intervention to improve. So we had them do a gap analysis. What is the standards for preventing those types of infections? How are you doing compared to that standard? And if there was a gap, picking then to improve that gap. And put in some things in place, like, for example, pneumonia was one of the areas of infection that people were having problems with. And when they did a gap analysis, one of the interventions to prevent pneumonia is good oral hygiene and oral care. And so this was something that, as they did an assessment of how were they doing, they found that there was opportunity there. And so they put in a robust oral care program, taught the CNAs, improved some of their products, and implemented that new process to close that gap in infection practices to prevent pneumonia. And then they were expected to collect some process and outcome data. So go ahead to the next slide. So we also did a facility readiness assessment because do you have, in sepsis treatment, you need IV antibiotics, you need fluid, want to draw labs. So we were assessing whether or not they had those things available. And if they didn't, then you would just have to alter what you did. But so we did a readiness assessment. Go ahead to the next slide. And then like I said, we did it over 6 months. Each meeting we had an agenda. Our first focus was on sepsis early recognition and management. And so that was the goal for this first meeting. And in that toolkit, there's agendas for each of the 6 meetings and all the content that is shared at those meetings. So typically you would, so you can see here that we reviewed what sepsis is, how do you identify it, how do you manage it, and then we gave them homework. So at each meeting, they would be given some tasks that they had to go back and do. So like at this first meeting, I'm going to talk with you about the early identification screening process in just a second. And they had to go screen 10 patients and try it out. And then come back the next month and tell us how that worked. So go ahead to the next slide. So the first focus was that early identification. Part of the program was we had them use a tool to assess the knowledge of their staff related to sepsis. And so this tool could be used pre and post education. So go on to the next slide. So this is the screening tool. We started off having the facilities use it in a paper format, but then the majority of the facilities embedded it into their EMR so that it would fit into their workflow. And the expectation was that they would screen to early identify sepsis at admission every shift for at least 7 days, or if someone was on antibiotics, they would continue to screen every shift. And most of the facilities ended up in their subacute area screening patients every shift for their time that they spent there. So I'm going to walk through the screening tool, and you're going to see some familiar terms that Tom talked about. So go on to the next slide. So the first step in this screening is to identify if someone has signs of SIRS, right? So they have that systemic response to that infection. So looking for the temperature, either high or low, the heart rate, the respiratory rate, the white blood count. And we adapted this to the nursing home facilities, the subacute facilities, and they know they don't get labs every day. So recommending not to use labs that are greater than 24 hours. Also, one of the signs of systemic inflammatory response syndrome is an increase in blood glucose. And so we had them check for if you had a glucose greater than 140, that was a systemic sign that that something more was going on than just a local infection. So if they had 2 or more of these SIRS criteria, then they'd move on to step 2. If they didn't, then there would be a negative screen for sepsis that day. So go on to step 2. So say the person did have 2 SIRS. So say they had a temperature, it was 100.8 and a heart rate of 100. And so they had those 2 SIRS. Now they move on to the next step of, does this patient have a known or suspected infection? So say your resident, now you're looking at your resident, they have an increased cough, they're colored sputum, and they have that temperature and high heart rate. Well, you're probably going to suspect that they might have a respiratory issue going on. Or maybe this person came from the hospital and they were being treated for pneumonia at the hospital, and so they were already on antibiotics. So if you check yes to either of those, then now that patient screens positive for sepsis. And we want you to, in the facility, monitor them more closely. So monitor their vital signs more closely because you want to look for changes. And then also begin to monitor their intake and outputs because you want to be able to look at their urine output to see if their kidneys are being impacted from this systemic response to the infection. So our patient has a known or suspected infection and 2 or more SIRS. Now we move on to step 3. And step 3 is, do they have any new organ dysfunction? right? So we're looking for changes in their oxygen saturation or their oxygen requirements. We're looking for a drop in blood pressure. We're looking for low urine output, and we're looking for mental status changes. If they have any one of those, that's new organ dysfunction. And now they have two SIRS, an infection, and new organ dysfunction. So now they screen positive for severe sepsis. If they didn't have new organ dysfunction, then you're done, and the patient doesn't have severe sepsis. They just have sepsis, and you'll continue to monitor that person closely. But if they do have organ dysfunction, then you need to review their advanced directives to see if we're going to treat someone aggressively, and then call the physician. And then we created an SBAR of what to tell the physician. So go ahead to the next slide. So if they screen positive, follow this SBAR. The situation is tell the physician that the resident screened positive for severe sepsis. The background is you're going to describe the positive SIRS. So in this patient, the temperature was 100.8 and the heart rate was 100. And currently this patient wasn't on antibiotics, but they have new cough, and along with fever and productive cough, that's you're concerned for an infection, and their organ dysfunction, say this person had some changes in their mental status. So, and then in your assessment, you're going to share any other vital signs. Then your recommendation is you're going to request, okay, this patient is screening positive for severe sepsis. The recommendation, so I agree with Tom and Ray and others that, our goal here is to try and prevent infections, because any infection can lead to sepsis. But sometimes our other goal is to recognize it early so we can treat it. And the standard treatment is to get blood cultures, to get a CBC, to draw lactic acid, and to get IV antibiotics going. And if the patient is hypotensive, to give fluid. And so those are the requests as you're calling the physician. Go ahead and to the next slide. So in essence, you're putting in a severe sepsis bundle when someone screens positive, and those are the interventions that you're doing. They're evidence-based interventions, plus you're increasing the monitoring of the person so that they're improving or not, because you might be able to. And one question that came up with people, can we really provide some initial management in a skilled nursing facility? And the answer was yes. So they were able to give IV antibiotics. They were able to get labs, and a lot of the facilities even were able to provide fluid and fluid management and prevent, and then watching them closely, because if they couldn't resolve that hypotension, or the condition was getting worse, then they would transfer them to the hospital. Go ahead to the next slide. We also tried to link it with the CNA, as Natasha talked about the importance of every employee, every person involved in care and working at a skilled nursing facility should understand what sepsis is. And in a lot of our skilled facilities, they had a program called Stop and Watch. So as they were interacting with the residents, if they noticed any of these items with Stop and Watch, that acronym, then they would contact the nurse, and the nurse would then screen for sepsis. So another way to pick up subtle changes and to early recognize if those subtle changes were the result of sepsis. So go on to the next slide. So this is the example of the action plan that all of the facilities completed. They got their team, they got medical staff support, they developed a screening and implemented a screening process, defined an education process for the staff, also education process for patients and families, and then an audit process to see if when they implemented screening, was it correct, and then their infection prevention plan that I talked about. So I'm going to the next two slides are just related to the audit screening process. When you put in a new process anywhere, you want to evaluate if it's being done and done correctly. And so that's what this audit process was. And then they would submit data into a portal in the MPRO at the MPRO website. So they looked, and they also, whenever they sent someone back to the hospital for any reason, if the reason was infection or hypotension, they would evaluate whether or not they appropriately performed the sepsis screening process and intervened appropriately. So go ahead to the next slide. So this was the example of our tool. They would do a 10% sample each day of the total volume of residents. So they had 50 residents. They would do a 5. They would review 5 that week. So it was an average daily census and 10% each week. And they would continue to do this audit once a week until they got up to above 90%, which took a little while to do that. So go ahead into the next slide. And go ahead to the next slide. So in part of this program and part of what's in the toolkit is you'll see all of the presentation slides, so nothing had to be recreated. So go ahead to the next slide. And probably the most important piece, or a pivotal piece, was as they came back to each meeting, they had to share in a round robin format how well their homework went and what issues they might have found. And the group then helped address issues and barriers. Go ahead to the next. So we know that we can provide some sepsis management as well as early recognition at skilled nursing facilities. Broad spectrum antibiotics, increased monitoring of patients, even early fluids can be provided. And if the patient remains hypotensive after you've given fluid or shows signs of decompensating respiratory status, of course, they need to be transferred to a higher level of care. And if a facility isn't able to provide IV antibiotics or fluid boluses, then get them transferred right away to a facility. Go ahead to the next slide. And I think this is my last. So what did we see? Well, we put 100 facilities through this program, and they got their screening compliance and accuracy up to above 80%. Some hit 100, and we saw improvements month over month. And we did see a reduction in hospital transfers related to sepsis. Also, the physicians felt and providers felt more comfortable keeping patients there to be treated. And because when they talked with the staff at the facility, they were educated on what is sepsis and how to manage it appropriately. So I think that's all I have. Go on to the next slide. Yeah. And I know we only have 2 minutes for questions. Sorry about that.
Any questions? I know there was one earlier asking about cost of care in Alaska, and Ray had a very good response to that in chat. If you guys have not had a chance to look through there, I also put a couple resources that we have through Mount Pacific. Pat, I'll have to grab the link for the toolkit. It's not working on my end. It's saying I don't have access, so you and I can get together and I can share that out with everyone either later today or tomorrow. And then Natasha just put the QR code to get into the Vivint Health programs and modules that she presented on. Do we have any questions? All right. Well, we will send out slides and recordings once they are available. And like always, they'll be also available on our website in the tools and resources page. If you guys have any questions or you want us to delve deeper into your own facility, please let your account manager with Mount Pacific know. Otherwise, we appreciate all of you attending. We appreciate our presenters, and have a wonderful rest of your day and week.
Thanks,
Thanks,
everyone.
everybody.
Thank
Yep,
you.
everyone.
You.